All right, let's go ahead and get started. Thanks everybody for coming to our Digital Scholar webinar today. This is hosted by the Southern California Clinical and Translational Science Institute at the University of Southern California and Children's Hospital, Los Angeles. My name is Eric Peterson. I'm the co-director of digital recruitment here in the CTSI. I'm also an associate professor of psychiatry and behavioral sciences, Keck School of Medicine. Thank you very much for attending today. I just want to go through a few things before I introduce our speaker. So everyone knows how to use Zoom now, but what we do is we use our Q&A feature to so you can enter questions in as they come up during the talk. So if anything comes up while Neil is talking, please type it into the chat. What I'll do is I'll compile all the questions until the end of the talk, and then he will field those questions. You can also type them into the Q&A section or the chat section. I'll monitor both. So we're really excited today to have Neil Baruz. He's going to talk about social and environmental determinants of health in clinical informatics. And he's also a member of our CTSI here. He's an associate professor of research in the Department of Population and Public Health Sciences. He is the Chief Research Informatics Officer at the Keck School of Medicine. And Neil joined USC in 2020. He came in with an impressive resume highlighted by work on the Human Genome Project, innovative industry experience, and a track record of helping medical centers use abundant data to transform their research and treatment programs. He's Keck School of Medicine's first ever Chief Informatics Officer, and so he's determined to be an enabling force for science that makes an impact on human health. So we're really appreciative of Neil for that. He earned his BS with honors in human biology and an MS in computer science and software engineering from the University of Toronto. He received an MBA in data analytics from Purdue University in West Lafayette, Indiana. So we also have Paul Kingsbury here, who's going to help monitor some of the slides, and I'd like to introduce Neil Baruz.
Hi, everybody, and I'm glad you guys are able to attend this seminar. Today, we are going to be talking about one of our favorite issues, which are social and environmental determinants of health. And specifically, today we are going to talk about how we can utilize them to have an impact in clinical informatics to actually affect real world issues. So again, welcome everybody. And so today we're going to talk about why the social environmental determinants of health are important. We're going to talk about a specific use case that we are working at CHLA, the Children's Hospital here in LA, about how we would incorporate these determinants as factors in decision making. With that use case, what we're going to do is walk through a scenario, as well as try to see how then we can not only apply this to clinical care, but also to research use cases. We're going to talk about where do social environment determinants of health measurements come from, how are they connected to patients, and a tool we've developed which will allow them to incorporate these into your own research, and hopefully talk to you guys about how, what are you guys doing in your research and how those could be incorporated, hopefully in the Q&A session. All right, let's go to the next slide. Oh, before we go to the next slide, you'll see that we have usually we have our CTSA slide deck, and here we have the slide deck from the National Center for Data to Health. This is because about 18 months ago to 2 years ago, we applied for a CD2H grant to really standardize and bring mainstream this idea of social and environmental determinants of health. And so you see this acronym SEDOH, it's kind of coined by us here at USC, of bringing together not only social determinants, but also environmental determinants of health. And this was funded by, there's some work here that was funded by the National Center for Data to Health, which helped us put these ideas forward and create a standardized maturity model, which we'll talk about at the end, as well as create this toolkit that we'll talk about in our use cases. All right, next slide. So, you know, for social determinants of health, this is actually a graphic from the National Academy of Sciences. The main thing that they're talking about here is for a healthy society, there's a lot of different factors that are in play. And so if you really want to look at health from a perspective of quality of life and throughout the whole spectrum from born, grow, live, work, and age, what we currently do in our healthcare system is really look at 20% of data, because we're looking at data that is generated or acquired during the clinical care component of that spectrum. And if you really look at all the different pieces that affect health, there's a lot more. There's 80% that's not taken into account a lot. So there's the physical environment, which makes up about 10%. There's health behaviors, personal behaviors, which is a very personalized idea. Also incorporated in personalized medicine, which make up about 30%. Clinical care, like I said, already makes up 20%. And there's this big iceberg that we don't usually tap, or at least until a decade ago was not talked about a lot, which are the social and economic factors, which are about 40%. And they make up things like education, employment, income, family and social support, community safety, you name it. And the environment part, which also affects health, especially in high industrial areas, as you can imagine, will be things like air and water quality, housing, transit, asbestos in the buildings, access to transportation and getting easy health care. Those all play into that as well. And clinical care, as you know, is really is once the people already have access to care, we get that from their clinical record, and the quality care is the outcomes they have based on the data that we have. And then the fourth part, which is the health behaviors, are made up of tobacco use, diet and exercise, all the personal factors that affect an individual. So if you look at this graphic, the interesting thing is that we have an opportunity to take a look at these factors because they have such an impact. A lot of these things are captured, perhaps not originally for healthcare, but they're captured for the government providing services as in census information or other information, or for housing if it's the Federal Department of Housing, that's the HUD, for example, and all sorts of other measures are collected. So we have an opportunity in informatics to take advantage of those if we can intersect them with the clinical care data that we already look at. And what this will allow us to do is really take those factors and affect equality, equity, and justice. So that takes us to the next slide. So what are we trying to do with this data is really, see how we can kind of change some of these outcomes that perhaps are barriers due to social or environmental aspects. So there's, 3 different ways to really address this. One is this idea of equality, where we provide a support mechanism equally across the board to allow what's it called, overcoming the barrier. So that's kind of depicted in the first graphic there, where there's a fence that's blocking the view of these 3 folks here, and we just give everybody a crate to stand on. So it's very kind of is equal treatment for everybody, but actually doesn't overcome the barrier by providing the support. The other idea is obviously equity, where we give everyone the support that they particularly need. So this is a concept similar to affirmative action to produce equity. So in this case, as you can see, we've gotten the child there a couple of crates, and he or she is able to now check out the game. The problem with this is that what happens is you have to make an individual assessment at the individual level for everybody, and that's quite costly, and that's hard, very difficult to do in order to get the equity across everybody. And the third part, really labeled justice here on the right-hand side, is that all 3 of these spectators can see the game without support or accommodation. because the cause of the inequity was addressed. So it's about removing the systemic barrier or the social barrier or the other barrier that may there be. And so this is the idea that we're trying to do of taking these determinants, these factors, intersect them with the clinical and health systems, and see if we can better address the needs of the individuals, because we understand the barrier that's in place in the first place. So with that, let's go to the next slide. Okay, so I mean, you're hearing from me, but what does all this have to do with clinical informatics? Well, basically, I'll read this quote out for you guys. If not developed and implemented, equitably, technology advancements could have widened disparities in care, as haves get more and have-nots are increasingly left behind. So we initially saw this also with the digital divide, as it's called. A lot of you may be familiar with this idea. When I mean, smartphones, thank God, have gotten really cheap, and data has gotten cheap, and they're way more prevalent. But initially, there was just a small proportion of the population that actually had access to smartphones. And if it wasn't for some of these government programs and others, all those apps and all that other cool technology developed would really benefit the folks who had access to those digital platforms, but it would have left a large chunk of the population behind that did not have. And at that time in healthcare, we were pretty cognizant of that. We were using texting as a mechanism, and we kind of still do for a large population, to make sure that we can keep the digital divide at a minimum. So texting, as you recall, unless you have those unlimited plans, used to be free for incoming texts for any plan. So that's a kind of an example of how we tried to keep the disparity between the people who had those facilities and they did not, as minimum as we could. So that's the idea with social determinants here, is that, okay, people who have access to healthcare, who don't live in a food desert, who have insurance, who have X, Y, and Z, are not the ones benefiting for the advancements in the health system or the clinical aspects of our system. And the people who do not, who don't live in, don't have access to those things, can also benefit from those. So with that, what we're going to do is walk into a use case. So to make this more real for everybody here. So with that, let's get into the next slide, Paul. Okay. So we have a co-director of mine in the CTSI, Dr. Juan Espinoza, is leading up this effort at CHLA. He's a clinician at CHLA. And our goal there is to demonstrate the use of social environmental determinants of health, where we create a novel risk stratification system. And we can publish these models from looking at data from a longitudinal cohort, and then apply that to help guide some decision-making in the specific cohort that we've chosen here is for pediatric asthma. So we've kind of nominated the pediatric asthma model, where as one of those frontline models, where the patient care decisions are we're going to provide and expose these factors that are either social or environmental determinants of health, what the clinicians will be presented with, taking these components, would be this summarized clinical risk score, which they get from the clinical data already. So that's not something new. But what we'll add to that is a social risk score and an environmental risk score. And each of these components, they're informed by multiple pieces of data. And so, for example, on the graphic that you see on the right-hand side, in the electronic health record, what we're going to try to add to that is data coming from the American Community and Housing Surveys, the GIS, which is the Geographic Information Systems, and the EHR itself. And so this would be kind of taking into account a lot of the census type data, which is the family income, the education, the demographic spread, the language breakdowns, you name it, that we capture, and those type of things, putting them together with the air pollution, water quality, building age, and all sorts of other aspects of the geoinformation systems, and then putting that together with clinical data we have in electronic health record, as well as medications and medication adherence data that we can get. So with that, all those will be put into a data integration and a predictive modeling algorithm based on this pediatric asthma cohort, and then taken and summarized and displayed in the EHR without creating a lot of complications, just kind of simple scores to, that help the clinician look at something and say, okay, you know what, perhaps this requires a little more inquiry. So if there is something that's, that they think that would affect the regimen of the treatment that they have planned out for the patient, they can say, okay, it's not just simple enough for me just, giving them a prescription. They may not be able to afford those medications, or they may not have access to those medications, or they may not be able to have access to transportation to get to the next follow-up appointments, et cetera, et cetera. Or there's an additional barrier where it's air quality or water quality issues that are affecting, the outcome of this individual. All right, let's go to the next slide. So to do that, MVP, for those of you who don't know, it's not your most valuable player. It's a minimum viable product. It's kind of a tech lingo for technology development. And so in order to kind of create this pilot, we've selected the minimal number of variables we could that all have high impact from the clinical side that would go into this algorithm. So in this particular case for asthma, this is obviously the diagnosis. And the diagnosis is the medical diagnosis that's in the patient's chart in the electronic health record. Medication, the list of asthma and other medications that are listed as active or the patient's currently taking, even if they're over the counter, the data is collected and stored in the EHR, so that's there. Medication adherence. Now this is slightly different. This is a new idea. This sometimes is available or not available. We're hoping it is available for this use case. This is fulfillment data. So one of the ways we try to measure how, if people are taking their meds, it's a proxy variable. You can write them a prescription, doesn't mean that they're taking their meds. But if they've potentially, gone to the pharmacy and bought the meds, that's what we call medication fulfillment. Then we can use as a proxy variable to say, okay, they're probably taking their meds because they're going and continuously getting their refills or whatever it is. And that's the fill data. And that, unfortunately, doesn't come from the EHR unless they're inpatient. It really comes from consortiums like your CVS and your Walgreens have. And sometimes I share that with us in the electronic health record. So that's where that comes from. Emergency department visits, ED visits, which is, how many times perhaps, they've had an attack that was exacerbated so far, they have to visit the ED. Hospitalizations, a lot of times those ED visits can result in hospitalizations. And how many times did that happen? Allergy testing, allergies are a known trigger for asthma. BMI percentile, which is the body mass index, that's stored in their chart as well. And, age, sex, and the what's it called, obesity all play a factor. Symptoms, they're also they change, especially on the children's health world. The symptoms are slightly different as the child develops. So those are also recorded in the EHR. So as you can see, most of these variables here are pretty simple. They were already in the chart. So, you can kind of look at those variables individually, but now the idea is we're going to take this data, especially the historic data, and put it into that algorithm. The next slide. So What are we trying to enrich this with? So the clinical data we kind of had, perhaps -1 or 2, like the medication fulfillment. What we're trying to enrich that data on the patient is with the social variables. So these are the social variables we've selected for this one. So a lot of these come from the American Community Survey, which is known as the ACS, and that's done. It's done every 5 years, and there's a 1-year, refresher on that. And so you'll see that in the source column there. So limited English proficiency is one of those things where, if somebody cannot communicate on what they have going on, they're not going to get treated the best. So percent of households with limited English proficiency, or if the neighborhood that they come from, is a good proxy variable to understand that. Inequality index, this is a special variable called the Gini inequality coefficient that's collected. I'm not going to go into that. You guys can look that up. A lot of information on that. That's also collected in the ACS. Social vulnerability index data that comes from the Center for Disease Control, the CDC. And they do that from kind of an epidemiological study where they understand, which populations are more vulnerable, et cetera. Like Indian reservations and things like this, they'll have a higher vulnerability index, for example. Income, this is collected not only in the census, but also in the ACS. That's median household income. And that gives a great example of what that community may have access to. These other income variables that kind of supplement that, enrich that, the 100 FPL and 200 FPL. And the education, percent of individuals age 25 and over with a high school degree. Hopefully, soon enough that's going to be changed into a college degree and above. But basically, it allows a good gauge of what percentage of people can understand and can understand that communication that they have with their provider. Food SNAP, or the food assistance programs that we have, what the prevalence of that is, low food access, et cetera, as you see from the USDA at the bottom here. These are all have to do with the idea of food deserts and others, as explained in the USDA database. So as you can see, these kind of all play into the social variables. So the next one we have is environmental variables. And asthma, obviously, the environmental variables are even have more impact because air quality plays such a big is such a big factor in asthma as an asthma trigger. So, but along with that, we also have population density. Housing, how old the housing is, it helps to understand what the codes are, and you can make a good estimate of if there was asbestos or not, or other building materials that are problematic. Ozone, PM 2.5, these are all air quality indicators. Water contaminants, these are taken from the Cal EPA, so this is California specific here, but I'm sure you can find these data points in your state as well. Just asthma prevalence. This is really good to understand, because there may be factors that we're not capturing, but the prevalence of the number of emergency visits, for example, like it says here, is a very good proxy to understand the other factors that may be going on, like other triggers that we may not have access to. Park access, this allows green spaces and other things. Traffic density, obviously, with the traffic pollution. Next slide. So what does that all look like at the end of the day? So we've talked about a lot of different factors. Most of them, they're accessible via various data collection schemes or mandates or databases. We put that together with the EHR, including medication fulfillment, et cetera. And we want to make something very simple available to clinicians. So this is a mock-up of a screen in Cerner, which is the electronic health record used here at LA County, as well as CHLA, as well as Keck Health System at USC. And this is a patient page where you can see easily an environmental risk score and a social risk score. So we want to make it as simple as that, where, and some of these, what's it called, these input variables are highlighted below that, like population density, housing year was built, air quality, et cetera. And obviously make it easy if people don't understand those variables. And I'm one of those. Sometimes I have to go and look up what a 223 means. And so they're hyperlinked, and those are all available directly to the clinician right there. They don't have to go find these. And if they want to know what the collective score means, there's a what does it mean hyperlink right there as well. But the bottom line about this is that you can put that together with your care plan for the individual. You can take into account if they have high environmental risks, or what does that mean? If they need to do something, or if they should get a HEPA filter in their house because the housing is too old, or if the social risk score is high, maybe you can connect them with community services or other things going on in the neighborhood, or a support group, etc., or other government programs or transportation programs or whatever. Or with the food program if the food is an issue, etc. So that's the idea with this, and and this very easily can come back. I mean, it makes it easy for the clinicians. It's right in the EHR they're already looking at. They don't have to open up another tool and figure these things out. If we can automate that from a clinical informatics perspective, this is a lot of value. And so as you can see, this can totally be a game changer. So this is something we're working on in CHLA. It's already underway. What we're going to flip to now is how we're trying to use all of this that we've showcased here in this, this use case on the research side. So with that, I'll jump into the next slide. So these are some of the similar variables that you saw. That we had on the clinical use case for CHLA. But as you can imagine, on the research side, you don't have the EMR, so there's no electronic medical record. You can obviously request that data and put that together. What we're talking about is just being able to understand the social environmental determinants and their effect on the population. Sorry, one second. So the American Community Survey, the CDC data, the Cal EPA data. There's this Esri business analyst thing, which really takes the census data into account, and we pull from that. That's the data source. The sc-ctsi data, which is prepared by our own USC Center for Spatial Sciences. The USDA data for the Food Access Research Atlas, and NASA data for a lot of the environmental data aspects that we pull. So all those things, what we're doing currently is we are building interface. We built interfaces to them, and we're pulling data from those. So next slide. So those are data. The one I showed in the previous slide is what we want to use. But before we get into that, what's currently going on? So currently what happens in the research scenario is that we have a tool like I2B2, of which a screenshot you can see on your screen. What that is used for is for cohort discovery. And most of the time, what a tool like that has is basically is sucked in from the EHR through a data warehouse and populates this tool, and allows you to do some really good clinical queries to find your cohort for a clinical study or a research study. So in this case, for example, simple Boolean logic in I2B2, they're looking for people who have type 2 diabetes and hypertension, either primary or secondary, and you can go on and you can build a whole Boolean logic query there. You can either and or not, which is exclude here, highlighted here. So you can build those type of queries. So usually with that, what we do is we're trying to find a cohort based on the electronic health record data. What we haven't been able to do, because we don't have the data on the patients, to say, okay, how is one group doing better than the others because of these other factors, which may be social or environmental factors affecting the group's outcome. And so with this project, we're trying to change that. So if you go to the next slide, Paul. So this is what we've done. We're going to be flip-flopping between these slides a bit, so I'll try to go slow. So this is basically the ontology tree And this snippet that you're seeing is only of those social environmental variables that I talked about. If you go back 2 slides there, Paul. So these are the data sources that we looked at. We want to have variables from these data sources available to build our Boolean logic query. So go back and go forward 2 slides. So these are these variables that are coming from these different data sources, and all of them, you know, in the actual tool, if you hover over, you'll be able to see the description, etc. And so here on the left-hand side, you can see that there's air quality indicators all the way from nitrogen dioxide, ozone, the PM10, P2.5. And on the right-hand side, you can see a lot of the social ones amongst them, like ethnicity and food and housing and median household income and alcohol access, drinking water access, you name it. You know, your demographic stuff like race, ethnicity is always there as well, but along with that, we have all the other variables pulled in, like the social vulnerability index at the bottom. So what you can do now is have access to all these search variables that you can drag and drop into the tool. So if we go back up 1 slide, this was the screen for your query engine. So as you can see in the first box, somebody dropped in, you know, type 2 diabetes, for example. And then they said, and in the second box, they dropped in primary and secondary hypertension, for example. In the third box, you could drop in, you know, where household income is less than or greater than X, Y, or Z. So this now allows us to make compound queries and incorporate these social environmental determinants of health. And this is going to be a total game changer, because now you'll be able to see and analyze these different populations of what's going on. All right, let's go forward. So how are we doing that? So this is where we're getting to a little bit of technical clinical informatics part of it. So this is what our architecture and data flow looks like. So we showed you that table of the various data sources that we have. Well, that's great. We have those data sources. Well, how do we know, you know, those factors affect the patients that we have? So what we do is the good thing about electronic medical record is there's a list of addresses, that last known address that people have. We can take those addresses and then geocode them. Geocoding means that we can take an address and either by census tract, similar to how the postal offices, they have a zip code and then a 4-digit zip code. Similarly, the census tracts also, and census blocks also have their own coordinate system. And what we do is take an address and run it through a translating engine, if you can imagine that, and geocode those addresses. Geocoding means that they get an ID number that reflects that particular coordinate within the census database. Once we have that those addresses geocoded, what we can do is the data that you see in the social environment determinants, those all are based on those coordinate system anyway. So we can intersect those or join those 2 elements, and voila, pretty much what we've done is now put together the background information for that geocoordinate or that location, what the social environment variables and determinants look like. So we go to the next slide. This is, again, cartoon example, so bear with me, about what the data warehouse looks like, the data behind what's powering perhaps I2P2 or any other data warehouse, where you have a medical record number, you have the patient particulars, lots of other information about their clinical record, and the address, right? So they usually have an address there. And so if you go to the, go forward. So what we can do there is that this is more so for the sense of kind of obscuring the identity. We've generated a random number for them, and then an off-campus or an external server. What we do is take that number and the address, those are 2 elements we take, and do a lookup with the census geocoder. Now it can be an external server, it could be a local server, it doesn't matter. We kind of use the census server directly, which has an encrypted channel to be able to look this up. So basically, in essence, we're not sending any identifiable information. There's basically a randomly generated ID and an address, which the geocoding system would already have anyways, or the post office would have anyways. Like you can imagine when they do the post office verification for your Amazon order. Similarly, this would just go and do the lookup. So hit next. So there you go. You see that last box got populated. When we do the lookup, what it provides us is this ID called the census tract ID. And that in some sense is an ID to the geolocation coordinates within the census tract. All right, let's go next. So now if you look at the within the census database, which is the top table, you can see that there's a census tract ID like we saw in the last slide. And that is where the census data, how the census data is stored, all the other data sets that they've collected, and the analysis that the Census Bureau has already done. And in this example, percent of Hispanics in that geolocation, a percent below federal level, for example, the median household income, and all the different variables we showed you. Obviously, this is just a mock-up, so we're just showing you a couple of these here. There's a lot of other measurements, each one specific to that coordinates within the census tract ID that covers. So what we're able to do, you see, oh, sorry, go back, Paul. What we're able to do is suck that into our patient. So we have that mock patient. We can pull for wherever the census tract is the data that we need and enrich that record. That's the bottom table there. So basically we have that random number that you remember for the patient, their address. Based on the address, we pulled in not only the translate to the census tract, but now we're able to do the lookup and find these other variables that are the social determinants here. All right, next. So what we do with that, we're showing you kind of all the steps in between so you understand the informatics part of this. We take that information, which is in the bottom table, which you saw we just created by doing that lookup, and we reverse populate the data warehouse. Now the data warehouse has been enriched, as we call it, because we've added variables it did not have by doing this join and this lookup and these number of steps we showed you. So we basically now have an MRN, the patient name, the address, all the other clinical information that was there. You know, we didn't add that, but now as an example, the demographic or the income level or the other social environment determinants of health variables, we're able to add specifically to that patient and their last known address. And then we can get rid of all these this stuff that was in the making, right? All the information we didn't really need. It was really a means to be able to enrich the data warehouse. So all that is gone, but we've captured all the pertinent information, and now we have a database that's fully enriched with these external third-party data points that we did not have. They're specific to that individual patient. All right, next. Okay, so actually let's go back to the last slide. Yeah, so as you can see, this is what we take now. And if you go back to the ontology slide there, Paul. Thank you. So all this ontology tree that you see out here, you know, all these indicators now are actually available. So when you plug these into your Boolean logic query, they're able to just you know, build that SQL behind the scenes on the data to say, okay, find me people who have, you know, air quality level of so-and-so, or food access level of so-and-so, or population density of so-and-so. And you're able to incorporate that into your query so that you can look at not just the clinical variables, but also put into effect these things. Especially imagine if you're trying to target a program in a specific income area, you can do that now, for example, etc. So this is how we actually bring this back into the data set and are able to populate the I2B2 in which you can do queries. All right. So with that, we're gonna throw a question at all of you to think about. So I'm sure you guys have a number of projects that you're working on. You may or may not have considered where social determinants or environmental determinants have an impact in that study. And you know, one of the things that we want you to think about is if you hadn't considered how these variables impact the outcome of a potential population, there are now tools available to be able to do that. So we'd definitely like you to consider that. And if you had already considered that and you didn't have a way to be able to easily do that, these tools that we've developed, especially the I2B2 tool, is a great tool for you guys to investigate and see how you can, right from the beginning, you can build that into your query. Even if you don't want to dissect a population, say, how many are below this or that, you can actually just at least get that variable and then see if that has an effect in your regression or whatever other analysis you're doing downstream. So with that, we'll let you take a couple moments to do that and consider that. And I want to hear comments and questions in the Q&A, like Eric said, about that. And because we're doing this a little bit without a breakout session, we're going to go to the last slide there, Paul. One after this one. Okay. So, I'm hoping that the things that we talked about, pretty much are no-brainer, right? These are things we kind of, once we look at them, they're not eye openers or anything like that. We know we should have considered these. These have an impact on what we're doing. But the use of this is not widespread. So one of the things that we did with the National Center for Data to Health here, USC, us and our CTSI group is the one who led this effort, was to say, okay, well, how do we measure institutions who are doing this well or not doing this well? So based on that, we created something called the maturity model. And maturity model exists for a lot of implementation scientists will know what I'm talking about. If not, there are ways for people to see how people are doing on a bunch of scales. So this is very typical. This color rainbow type of maturity model is very typical of informatics type of maturity models we develop, where we investigate how an institution or a health system or academic medical center or medical school, et cetera, are doing various things. And usually there are 7 levels, and this is kind of developed to that similarly. And the first level usually is where, there isn't much happening in terms of incorporating social determinants of health. This is what you saw in my earlier slide, where we said we're looking at 20% of the data when we're looking at assessing health of individuals. And this is between environment and social. This is probably an addition of 50% more. So this would get us to 70% if everybody was at level 7. And the verticals that we have here are simple. You can't look at this if you don't collect the data. So what we showed you today are tools to look at the easy work, right? We're just basically tapping third-party data sources and enriching data. Whereas this is it's a big leap. It gets us far along the spectrum. But at the individual level, we don't do assessments at individual level. Even in a neighborhood, not all fingers are the same length, right? The different people may have different situations. And to really achieve personalized medicine, we need to assess even the social and environment at an individual level. So those assessments have to be done. And so this is the idea of data collection at the individual level. Data collection methods, where is this done? Is it just done in research, like in a REDCap database? Or is it done at the EHR level? And the EHR level is very good because it puts it directly at like that algorithm we're developing in CHLA. What are the technological platforms that an institution has to collect this data? Is it standardized? Can you compare apples to apples? And this is something that we at USC are working on, as you saw with the various variables we've created. And there's a lot of new instruments actually out there as well at the personal level. And then the analytics capability. So we're developing these risk scores based on prediction and other statistical models. Are you looking at just the data collected as it is, or you're developing these things into these things? And then using that data. And so it's one thing to just collect that, put the risk score out there, how to use them, and then measuring the impact of the use of it. So this is kind of the maturity model for that. And it kind of, we're hoping that even we at USC, do well in this. Right now, we're not doing a lot. But this is, at least in our community, in the informatics community, is to get most of our, at least academic medical centers, hopefully above the yellow in this maturity model. And with that, I will stop talking. And Eric, back to you.
Thank you so much, Neil. Really appreciate this. This is really fascinating stuff and such a cool tool. So we appreciate you coming on and you and Paul showing us this. All right, so we might have some chat going on a little bit, but I'll throw some questions out for you in the meantime. Can you discuss the benefits of pulling in census tract data instead of trying to document social and environmental determinants of health for individual patients in Cerner? We'll start with that one.
Yeah, and that's what I was alluding to at the end with the maturity model, to be honest. So I think it's about scale and resources. So nothing beats a personalized, data collection, right? Like, that's what personalized medicine as well, right? For the situation at hand, how do you want to address it? But there's not enough cycles in the day. The clinician doesn't have enough time. Who's going to do this collection? Who's going to pay for this collection? All these things matter. They shouldn't, but they do. And so what we are doing allows us you to do is focus on the individuals that are high risk. So this by no means says don't do that. It says, okay, if it's a 0 to 5 scale like we showed you in the mock-up, if they're on 5s, go and ask those questions. It's worth every moment of time spent to do that assessment. But if they're in the green, they're at 0, 1. Maybe it's okay. You can overlook that. So I think it's at the end of the day, it's the combination that's really going to make this most sense, because food desert is a food desert. That's where they live. You don't need to ask them that. You can already get that information. That's kind of more of a black and white type of answer. But if there's a personal situation, or they don't, if they live in, let's say, like I used to live in Chicago. I live in Chicago and they're only turning on the heat at at a certain level, and they're freezing their butts off because they can't pay their bill. That's a real thing, and that's something they have to collect at the individual level. So those things do matter, but there are definitely, the benefit of this is that the environment data is not changing, right? Air quality data is not changing. You're going to be able to even ask those questions. The food access, the infrastructure in their neighborhood, no brainer. You can get that from the third-party databases. So I think it's the answer is both, but this is the easy stuff that we can do informatically. So we're going to go ahead and do that.
Great. Thanks, Neil. This is very specific, but I wonder if you want to take it. Does asthma risk correlate more with neighborhood socioeconomic status or individual?
There's a lot of studies out there. I'm actually a previous asthmatic and kind of grown out of it. So there's a lot of anecdotal stuff out there as well. But air quality does play a big deal. So you'll see some of these big studies where they're old manufacturing areas and those, the smokestack type cartoons, and there is more prevalence of asthma. We've seen that happen. The other thing with asthma is that asthma doesn't happen because of one thing or another, but the triggers of asthma tend to happen a lot more in socioeconomically deprived neighborhoods, et cetera. There's a lot more triggers. And so there has been studies about that. So again, I'm not the expert on that, so I don't want to speak to asthma, but definitely I've read some of those studies where the triggers, those are real. Those are geographic in nature sometimes, or socioeconomic in nature sometimes.
Thank you. This person stole my question too, but I think this is a really interesting one. So can the tool be used to pull social, environment, or info with de-identified data for research subjects if you have a list of IDs and their home address? So, we collect home address in research projects. If yes, is input one at a time, or can you submit a query to in a large batch?
So two-part answer, really, because I2B2, the tool is purely for cohort discovery and it's de-identified. And that's how we made it open, based on all the regulatory people who tell us what we can make open and available to everybody. So if you need to somewhere identified, you can contact the sc-ctsi, CRI, put in a request, and when you have an IRB, we can go ahead and we have a tool to do that. I think one of our team members, Praveen, is actually in the audience. So we can actually do that as well. But so I2B2, the answer is no, you can't just drop a list of IDs and home addresses. That's not what it's designed for anyways. You couldn't do that even for the clinical data. So it's a different type of tool. But what we're doing is we're developing something for REDCap, a module for REDCap. That's actually our next project, where you don't have to drop it. If you have already collected REDCap, we can make a module available that'll do the pull for you. So that's not done yet. That's the design phase right now. The technical infrastructure for that tool is the same that we've done for the I2B2. that steps, that flow chart that we showed you in the slides. So that if you have a request, just reach out to us. If you have a research project, we can figure out how to do that with you. We'll do it for you. But the idea is, how do we make this self-serve? And to address that, we're developing a REDCap module.
Thanks. This next question is, I think, pretty similar to that. But maybe before we get to that one, is this available for CHLA or UHC, USC electronic health records yet?
No. So the first use case we showed you was a mock-up, the one that had a Cerner page with the risk scores. That's where we want to go to. The second part we showed you is real, the I2B2 stuff. We've already done that. We've done that connection. We do the lookups, the whole temporary, the whole workflow that we showed you, the SQL join, the bringing the data over, the random ID, putting it back together, enriching the data warehouse. All that work is completed, and that's available in I2B2. And in fact, if you reach out to CRI, we could even do a training. We're going to develop some public training sessions as well, but I think we're going to set up some training sessions and stuff like that. But we already have an open, some office open hours where you can drop in and ask those questions from our teammate, Daniela Garofalo. She runs those. And so you guys can use those. So the I2B2 work that we showed you is already done and available. The CHLA work is in progress, because a lot of our work right now is focused not on pulling the variables, because I think we know how to do that now. It's really to develop that algorithm. So we're working with people in Viterbi and ISI, Information Science Institute of USC, to see how we can come up with those risk score algorithms. Once we do that, we'll see how we can write that back into the EHR. We're obviously going to CHLA first, because this work already started there. The asthma work, is the cohort that we've chosen, and it's obviously more pediatric scenario. So that's where we're doing it. For USC, what our plans are is we're going to incorporate all the work that you saw into our data warehouse project. This is something I lead as a CRIO. And the project is called the Health Data Innovation Program. So we're going to take all this stuff that we've done. In fact, we're already migrating this into our Health Data Innovation Program, where all these third-party data sets are already going to be there. This ability to link the records are already going to be there. But it's obviously going to be in a request-to-request project request basis. So like I said, you put in your request, you may not even know it. It may be running on the new data warehouse, and you'll get your results back. And so we were actually going to do this for all USC EHR records, where we have more control than CHLA. And another thing I want to add to you is we showed you something very simple with an address. The reality of it is nobody lives in one address. We're dynamic individuals, and so are our patients. So what we're actually doing is taking the chain of all known addresses in Cerner. As they change, they're not deleted. We keep those addresses, because a legal electronic record has to keep it anyways. And this allows us to, in a point in time, to understand air quality or their socioeconomic. So you can actually do retrospective studies and see movement and things like that. So I think the research project design can be quite innovative. The fact that we're doing this, we'll have a temporal intersection enrichment of where they lived and over time, and these variables. And I think once we have the REDCap module done, could even put in where they work, because a lot of people spend a lot of time, way more time where they work than they do perhaps where they live, or they commute. So you can see all those aspects as well.
Amazing. Thank you. Thank you, Neil. Thank you, Paul. I think we can wrap up now, unless you have any final thoughts. I don't see any more questions. So just want to thank you for delivering this awesome talk and for designing this tool. And we really look forward to seeing the future of this.
Great. All I will do is that if you guys want to know more, reach out to CRI. Paul, do we have an email address to plug or something?
Probably the best place to reach us is sc-ctsi@usc.edu.
Got it. Okay. So reach us out there. They'll find us. Sorry, I didn't have that handy. And then we can talk more about it. Or if you have a ready project, we can see how we can incorporate this for you now.
Great. Okay. Thank you so much. And Paul plopped that in the chat too. And also Karen just put in a link to a very brief survey if you want to give us some information or just your thoughts on the talk, as well as any upcoming webinars you'd like to check out. So thanks again to Neil. Thanks to Paul. Thanks to Karen. and we will see you all next month. Take care, everyone.